So my topic that I've been given today is what's next? Treatment options for Waldenstrom macroglobulinemia after prior therapy. In other words, what do we have for relapsed and or refractory disease? And these are my disclosures. I would like to start off with a patient, a very interesting patient that I saw more than a decade ago, back in 2014, and I've had the fortune of following her. This is a young lady, 56-year-old, and was originally diagnosed with WM back in 2014 when she was found to have an IgM level that was exceedingly high, about 5,300. And fortunately, she did not have any symptoms at the time of the diagnosis, and she did not have very significant cytopenias or abnormal hemoglobin or low platelet count. And as such, while she was at the time of the diagnosis at the outside facility, she was told that she should be starting therapy because of exceedingly high IgM levels. She came in for a second opinion, and based on her history and symptomatology, which was nothing, and comorbidity, she was very healthy, we decided to observe her. And now it's 2026, and we are continuing to observe her. I just want to highlight the fact here that there are clear indications for the treatment of WM. Unless the patient meets those indications, there is no value to initiating or commencing therapy early on. All we would do to the patient is give them side effects, which we know for sure they will encounter if we start any treatment. And we wouldn't necessarily change anything in terms of the overall outcome or overall survival of the patient by introducing therapy early on. And as you can see here, these are the distinct symptomatology that we typically look out for. Specifically, constitutional symptoms or B symptoms, such as fever on a regular basis that's unexplained, and drenching night sweats, symptoms of hyperviscosity, such as headaches or blurring of vision, or lightheadedness, or bleeding, nasal bleeding, and or gingival or gum bleeding. If there are specific lab abnormalities, if patients have debilitating neuropathy, if they have concurrent symptoms of another condition which is seen in about 8 to 9% of patients with Waldenstrom, and that is AL amyloidosis or AHL amyloidosis, which can present in a variety of non-specific ways, including shortness of breath, swelling of feet, and diarrhea and or constipation, pain in the jaw while eating, bruising, etc. So there are a number of symptoms that we like to find out whether the patients are suffering from those or not. And in the absence of those symptoms, that have to be, mind you, clearly attributable to WM, because these are non-specific symptoms. There could be a variety of different reasons which are not necessarily associated with WM that could potentially lead to these symptoms. And our job is to figure out whether they are WM related or not. And actually, very recently, over the past year or so, we've been able to develop a staging system. This is for active WM patients. What I discussed earlier was a patient with smoldering Waldenstrom macroglobulinemia, which is seen in about 20 to 25% of patients at the time of diagnosis who are completely asymptomatic at the time of diagnosis. Here, at the time of active disease or diagnosis of active disease, when one is ready to start treatment, the clinician should be looking for certain laboratory parameters to further stage the patient. Age is a very, very important parameter that determines prognosis, but there are others as well, including albumin levels, which are checked in the blood. Albumin is a type of protein, and if it is low, then that could potentially increase the stage and in turn lead to a relatively inferior prognosis. And there is another enzyme called LDH, which is elevated or increased in about 15 to 20% of patients at the time of diagnosis, and that could potentially put them in a higher stage category. And this staging system, called the modified staging system that we developed, was also verified by the US Oncology Network last year in over 900 patients. And it clearly works, as you can see, the separation of survival curves. But what we also developed through this IWWM workshop is this consensus criteria to come up with what exactly constitutes high risk in patients. And it is not only the high risk modified staging system, but within that category, if the highest risk patients have also high levels of another molecule called beta-2 microglobulin, that's another protein, then they are exceedingly high risk, or they have one of the genetic abnormalities in the Waldenstrom cells called TP53 alteration. TP53 is considered a master gene that helps suppress tumor or cancer. And if that gets affected or impacted in a way that it is unable to perform its function, it's considered as mutated or altered. This TP53 gene is present in the short arm of chromosome 17. All of us have it, but if it is deleted in WM cells, that leads to pro-survival signaling and allows WM cells to grow uninhibitedly. So at the time of seeing a patient with so-called relapsed and or refractory disease, there are a number of factors that we have to take into account. Do we really need to change therapy that the patient is receiving? Is the patient truly resistant to the treatment that they are getting? Or if a patient has in the past received what we call fixed duration or finite duration therapy, such as chemoimmunotherapy, is it necessary to consider restarting that therapy? And while our options have considerably improved today in 2026, there are certain patients who still prefer to receive that same treatment that worked for them 10 years ago because it was just a 6-month treatment duration and they felt that they were able to tolerate it fairly well. But we have to take into account many factors when we determine what treatment to start at the time the disease comes back. Is it what we call a biochemical progression only? Now, I'm going to explain what this terminology means, but in order to explain that, we'd have to go a little back because the IgM levels are routinely high in patients with Waldenstrom macroglobulinemia that have active disease. And fortunately, we are able to use this IgM level as a surrogate marker for response. This is something, a protein, an immunoglobulin, an antibody that is secreted by the Waldenstrom cells. And if the cells are killed, that in turn shuts off what we call the factory, and the product, in this case, the IgM level, would then go down. And if the IgM level is going down, that indirectly tells us that the factory is shutting down. In other words, WM cells are getting killed. On the other hand, if the IgM levels go up, that could potentially mean that there is increased cancer burden and WM cells are starting to grow back again, and we might have to do something about that. So it's called biochemical progression if we find the IgM levels going up at least by 0.5 gram and at least 25% from the nadir, the baseline level, or the lowest baseline level that they were able to achieve. And just because somebody has an increase in IgM level doesn't mean that we have to pull the trigger on reinitiation of therapy. All it means is that we need to follow the patient closely. The symptoms that were responsible for starting treatment initially are the symptoms that would be responsible for restarting therapy. In other words, the indications for treatment initiation have not changed. They are the same in the frontline setting as they are in the relapsed refractory setting. Having said that, we have to also look at, when we are trying to decide what kind of treatment to give, is whether it's an aggressive relapse. What if a patient presents with what we call hyperviscosity or significant lymph node enlargement that is potentially compressing some, let's say, ureter that could in turn damage or potentially damage the kidney function? Is it something that is particularly causing a lot of symptoms and there's a lot of heavy tumor burden that we need to start treatment right away? And is it that the patient is developing these symptoms while on some treatment? For instance, are they developing these symptoms on BTK inhibitor, such as ibrutinib or zanubrutinib? Or is the patient relapsing after having received treatment several years ago? And what specifically are their symptoms? So we take a detailed history, which is exceedingly important because the circulating IgM level can cause a lot of funky things. It's the circulating IgM protein can wreak havoc or can be just an innocent bystander and may not be responsible for anything. Our job is to figure out whether it is linked or it isn't linked. And here you can see a bunch of side effects. I haven't listed all of them, but we specifically ask about all these things, including unintentional weight loss and headaches and Raynaud's phenomenon, rash, tingling and numbness in hands, feet. But we also are looking at certain laboratory abnormalities because fatigue is a very common symptom as well, and low hemoglobin can cause fatigue. But we also know that patients with Waldenstrom macroglobulinemia can have low hemoglobin as a result of iron deficiency because of poor absorption, and merely correcting iron levels could potentially avoid giving full treatment directed towards WM cells. We have to look at cryoglobulin levels, which are essentially IgM, which can precipitate in the cold and can cause dysfunction, rash, or neuropathy, or damage to the kidney. We have to look at cold agglutinin titer, which is again antibodies to red blood cells, again IgM, that can lead to clumping of red blood cells. And we have to also look at what we call hemolytic anemia as a result of bursting of the red blood cells. We have to also look at whether the patients are getting infections repeatedly and if the immune system is extensively compromised. We have to perform a CT scan of the chest, abdomen, pelvis, or look at the PET CT scan. It's one or the other. But importantly, we have to also look at two mutation signatures, and these are MYD88 and CXCR4, something that all patients with Waldenstrom should ask their clinician about. And obviously, the bone marrow biopsy, which can show a variety of different types of white blood cells that are abnormal. In this case, this is what Waldenstrom cells look like in the bone marrow aspirate. And here's what we see within the cell. This is a cartoon, but what you can see is that there are a bunch of proteins within the cells that can potentially serve as a target because they are pro-survival proteins, and they lead to some downstream signaling that in turn leads to growth and uncontrolled growth and proliferation of Waldenstrom cells, and in turn secretion of IgM in excessive amounts. Now, MYD88 mutation is present in 90%, over 90% of patients with WM. And there is another mutation called CXCR4, which is seen in up to 40% of patients. And CXCR4 confers additional resistance to certain treatments, specifically BTK inhibitors, and what we have now found out to even chemoimmunotherapy such as bendamustine and rituximab. But there's a constant crosstalk that is going on between the tumor cells, in this case the WM cells, as well as the surrounding bone marrow stroma, the other cells that are in fact nurturing those tumor cells and have somewhat been harnessed by the WM cells in such a way, co-opted by the WM cells in such a way that they work in favor rather than against the cancer cell. And the cancer just continues to thrive. Mast cells also are playing an important role in the growth of these WM cells within the marrow. Another thing that's important at the time of deciding what to give because of relapse is to look at what prior therapy patients have received. Now, there's I think another session going on about the prior therapy received, so we are not going to discuss this in great detail, but suffice it to say that many of these treatments have not been compared head-to-head in a randomized controlled trial fashion. As such, we have to go back to the studies and look at whether the patient population is similar or are we truly comparing apples to oranges. What we are trying to figure out here is, with all these options, which is really good for us, which one is the best? And the gold standard in these scenarios for comparison is a randomized control, what we call a phase 3 trial that would give us high quality data, high level of evidence to make a clinical decision with great confidence. Now, in the absence of a randomized controlled trial, we could do what we call retrospective analysis to see which one looks better amongst the patients we have treated. And one such retrospective analysis from the Mayo Clinic in Rochester was this analysis comparing 3 regimens, bendamustine rituximab, DRC or dexamethasone, rituximab, and cyclophosphamide, and another rituximab-based regimen called BDR or bortezomib, which is a proteasome inhibitor, a completely different type of drug than other 2 regimens I talked about, in combination with dexamethasone, which is a steroid, and rituximab, which is a monoclonal CD20 antibody that attacks WM cells specifically and some of the other cells on which CD20 protein is expressed. And what we are finding here is that the patients who receive bendamustine rituximab, their likelihood of progressing and requiring treatment is much lower than, and that's the green curve, than the patients who have received DRC or, for that matter, bortezomib, dexamethasone, and rituximab. So time to next therapy is longest in patients who receive BR compared to the other two. Having said that, regardless of what patients have received, fortunately, the overall survival is not impacted as long as they have access to other drugs downstream, should the disease come back. But what we have also found out is that specifically in patients who receive bendamustine rituximab, if the disease comes back within the first 2 years, that to us tells us that this is a nasty disease and we have to think outside the box. If we don't, then those patients won't do well. On the other hand, and that's called progression of disease within 2 years or 24 months, that being an independent marker of prognosis. On the other hand, patients who have received this regimen and have been able to survive without disease progression for the first 2 years, their lifespan has been found to be very similar to the general population that's age and calendar year matched and gender matched. So overall, progression of disease within 24 months is a surrogate endpoint that we need to be mindful of. But then there are a variety of other factors that we have to take into account, including what we call physiologic or biologic age, not the chronologic age. I could find a 70-year-old very fit individual and a 55-year-old highly unfit individual with a number of comorbidities like diabetes, hypertension, etc. Then we have to look at the mutational status. As I said, CXCR4, TP53, etc., could potentially tell us that this might be a harder to treat disease. And then obviously accessibility to different therapies. Maybe BTK inhibitor is not available frontline and it's not available in a number of countries, including a number of European countries. Maybe it is the patient might not have access to bendamustine, but might have access to bortezomib. So you have to look at all those things. Thankfully, in the US, we have access to all these and more. And obviously, we have to look at the patient preference because the approaches vary vastly. We are talking about intravenous and injections, etc., for a fixed duration versus giving oral therapy on a continuous basis, which can sometimes be preferred by the patients, but not always, because they don't want to just continue taking it forever, especially if it is not going to cure the disease. And like I said, the nature of relapse, aggressive versus just biochemical progression. And with biochemical progression in the absence of symptoms, we can just watch. What WM-related complications were there? Did the patients have renal kidney dysfunction as a result of cryoglobulinemia, where we can't afford to wait on the patient? Or did the patient become so symptomatic with blurring of vision that with the elevated IgM level that we know that at certain threshold, no matter what we do, they are going to continue to show symptoms. So we need to be mindful of those factors and in such cases start treatment promptly. And obviously the prior disease characteristics that we talked about, as well as previous treatments which the patient may or may not have tolerated, which the patient may not be now sensitive to, because the WM cells are very smart. They can mutate, they can lead to certain expression of certain proteins that could potentially help them survive and make them more resistant to the treatment that we have to offer. Then obviously the composition of the bone marrow compartment, so whether it's more lymphoma cells or plasma cells, whether they are CD20 positive, whether the patients have previously received, for instance, a CD20 antibody such as rituximab, and what if the rituximab was given just a year ago and they relapsed? Do we need to repeat rituximab or can we switch over to something else? What if the patients are intolerant to certain BTK inhibitors such as ibrutinib? Could we switch? Could we reduce the dose? And the answer to both those questions is yes and yes. So we could reduce the dose and see if the patient's tolerability improves, thereby allowing them to stay on the previous treatment, because we know that once we reject or throw that treatment out, we are not going to come back to it. So we better be careful that we have squeezed the lemon to the fullest. We also want to make sure that the response is good. Sometimes even lackluster responses or depth of responses are acceptable as long as patients are able to remain symptom-free. Because the patient came to me with certain symptoms, drenching night sweats, weight loss, loss of appetite, low-grade fevers, severe fatigue, and all those could go away without substantial dent in the IgM level, in which case I would prefer to keep the patient going on and over time see if the patient continues to respond, because typically with BTK inhibitors, we continue to see deepening of response over time. And we shouldn't confuse the withdrawal symptoms. If we have to abruptly stop treatment, patients can develop certain symptoms like fever and severe fatigue, shortness of breath, etc. That shouldn't be confused with relapse of disease. We know the timing fits very well with the symptoms, and with reinitiation of treatment, those symptoms would potentially go away. Or if we can't reinitiate because the treatment was stopped for a specific reason, such as if the patient is going for a surgery or something, we could potentially give steroid for a short duration of time in order to tide over those symptoms. Again, if we take our foot off the pedal, in this case, if we suddenly remove the BTK inhibition, there can be a rebound of IgM, and that can, by a novice, be determined as relapse. And we have to be very careful about it, not to call those patients as having had a relapse, but an IgM rebound, where we know that typically after restarting the BTK inhibitor, the IgM level would go down again. Again, one case of a lovely lady that I saw back in 2013, she presented with huge lymph nodes in her neck, armpits, etc., and also severe fatigue. What was noted was an IgM level of 4,500. So just the level itself, as you can understand, the previous patient had 55, roughly 5,300. This one has 4,500, but this one has many more symptoms. So the levels don't necessarily correlate with symptoms. There can be a tiny amount that can cause severe symptoms, and there can be a high amount that in that specific patient may not cause symptoms. But this one did have low hemoglobin and was started on DRC plus Revlimid or lenalidomide on a clinical trial, but she was unfortunately intolerant to rituximab and started developing really high-grade fevers, as a result of which we had to promptly switch treatment, which helped her get into remission up to September of 2013. And at that point, given that she was young, we decided to do what we call stem cell harvest, keep her stem cells, which is not something we do routinely today, now that our options have improved vastly. But after giving her fixed duration of therapy and collecting her stem cells for future use, we started observing her. And fortunately, a couple of years later, in November 2015, she presented with what we call hyperviscosity syndrome, with blurring of vision, required emergent plasma exchange to remove the culprit, in this case, high IgM level, was then given bendamustine alone, because just recall that she was intolerant to rituximab. And then once we found that she was chemo-responsive, we took her for autologous stem cell transplant. Now, that was in February 2016, around which time BTK inhibitors, specifically ibrutinib, was already introduced. And we gave her the option, but she said, I just want to get over with this. I don't want anything after the transplant. Just let me use this. And she remained in remission for close to a year and a half. Unfortunately, started seeing worsening of her symptoms. And at that point, we did the MYD88 testing, which fortunately she showed a mutation, which in this case allowed us to give her ibrutinib, which doesn't work in the absence of the mutation, but does work in the presence of mutation. Fortunately, the mutation is seen in over 90% of the patients, and to date, she remains in remission, but has developed hypertension as a result of chronic use of ibrutinib, and hypertension is high blood pressure is a known side effect. So when do we consider retreatment? We consider retreatment if the previous regimen is successful and is for definite or finite duration, but was given a very long time ago in the absence of other options. And for instance, if patients are resistant to chemoimmunotherapy and they start showing after 6 months of stopping chemoimmunotherapy, they start developing symptoms again, those symptoms could potentially be resolved by use of covalent BTK inhibitor, as was done in this patient's case, where even though she relapsed a year and a half later, having undergone high-dose chemotherapy immediately prior to stem cell transplant, we didn't think it was advisable to give more of this chemotherapy, and by that time, we had this great option to use. And we have to also look at the bone marrow reserve that patients have. Are they very anemic because of previous therapy that we cannot use more of what we call cytotoxic or cell-damaging therapy? Because there's a lot of collateral damage, so to speak, with certain treatments. They do not only kill the Waldenstrom cells, but as many of you in the room know, they can kill normal cells as well. And again, treatment goals, it's important to revisit that because deep responses may not always be possible. And in case of clinical benefit, we should be able to continue that same treatment over time. And it is, in a large majority of patients, possible to see deepening of response over time on continuous therapy. One more case, I promise this is my last one. 67-year-old gentleman I saw 10 years ago, again with night sweats and weight loss and fatigue. MYD88 mutation was noted. He was anemic, started on bendamustine rituximab, then relapsed, given Cybor-D, and then relapsed again, given zanubrutinib, relapsed again, was given a BCL2 inhibitors on a clinical trial, and this was called sonrotoclax. Unfortunately, recently, over the past year, he developed a second cancer, which was not related to his prior treatment, but a second hematologic malignancy called MDS with a specific mutation. And that essentially led him to become transfusion dependent, as a result of which we were dealing with 2 cancers at the same time. But fortunately, even though his disease worsened over time or relapsed after giving zanubrutinib, we were able to introduce pirtobrutinib, which is a next generation BTK inhibitor, and now he's transfusion independent and doing fairly well. But he's also receiving treatment for his other blood cancer. So we'll just go back a little bit to show you how much of progress has been made over the course of specifically past decade. And it all started off with the discovery of MYD88L265P mutation in WM cells, and subsequently the CXCR4 mutation and their clinical impact, and certain trials, specifically this ASPEN study where two BTK inhibitors were compared head-to-head. The drug company, in this case, the manufacturer of zanubrutinib, took a very high risk. It put its product against the other drug that was already on the market. So they didn't know what the final outcome was going to be, but fortunately, the drug was very well tolerated. Unfortunately, at the time of initial assessment, the study did not meet its primary endpoint. Zanubrutinib appeared to work just as well as ibrutinib, but it was much better tolerated. It had a superior safety profile. So it was essentially what we call a negative study. But the FDA looked at the data very carefully and thought that it is worthwhile approving this drug as an option to use. Over time, we found out that there was actually deepening of response in the zanubrutinib arm, and in fact, it was eventually found to be superior even in terms of efficacy in comparison to ibrutinib. And specifically in patients who have CXCR4 mutation, those patients do much better with zanubrutinib compared to ibrutinib. Additionally, patients who don't have the MYD88 mutation, those patients are able to tolerate as well as have a good impact from zanubrutinib and are able to show response. And given its better safety profile, almost 2/3 of the patients are still on zanubrutinib after 3.5 years, in comparison to only half of the patients who were on ibrutinib after 3.5 years of starting treatment. And because I just showed you the safety profile of zanubrutinib is better generally in terms of the rates of high blood pressure, irregular heartbeat or atrial fibrillation, as well as high-grade bleeding. But zanubrutinib does cause more neutropenia or what we call damage a specific type of white blood cells, and this is something we have to be mindful of in comparison to ibrutinib. In the subset analysis of this ASPEN study called the biomarker analysis, what was found was that in general, patients with CXCR4 mutation have some degree of resistance to BTK inhibitor, as do the patients with TP53 mutation. Having said that, in those patients, zanubrutinib works better in comparison to ibrutinib, and therefore should be the preferred drug of choice, both for CXCR4 mutation as well as the TP53 mutant population. Fortunately, there are other studies as well, including a relatively large, I should say, phase 3 trial called the INNOVATE study, which used ibrutinib in combination with rituximab and compared it with rituximab. In the control arm got rituximab plus a placebo. And there was a significant improvement in the depth of response, the overall response rates, etc. Additionally, the progression-free survival of patients was better. Having said that, this study included both treatment-naive as well as relapse-refractory patient population, and it didn't quite matter whether the BTK inhibitor was given upfront or as second or third line, as it worked equally well. So if you haven't received, that's okay. You can get it at the time you need it. Fortunately, there are many BTK inhibitors, covalent BTK inhibitors, that have a similar efficacy profile, especially the next generation BTK inhibitors, and in terms of safety, they are fairly similar as well. So going on to pirtobrutinib, which is the next generation BTK inhibitor. It's a non-covalent BTK inhibitor, inhibits both wild type as well as what we call mutant BTK. Over time, on ibrutinib and zanubrutinib, acalabrutinib, patients can develop mutation on that target, the BTK itself. Fortunately, pirtobrutinib can salvage those patients because it works even in patients who have some mutation on their BTK enzyme. And as such, it can be used in patients who are relapsing off of ibrutinib or zanubrutinib or acalabrutinib. And even among patients who have seen a prior covalent BTK inhibitor, the very good partial response rate is seen in 1 out of every 4 patients that get this agent. And in a recent update last year at the American Society of Hematology meeting, after 3 years of follow-up, what was found was that it can keep the disease at bay for close to a year and a half, even if patients have been exposed to BTK inhibitor before. And if they are BTK inhibitor naive, those patients are still continuing to show deep response. In fact, pirtobrutinib is even better than zanubrutinib in its safety. I would like you to focus on the right-hand side column, the last column, where you see all these zeros, which means the grade 3 or higher side effects are not noted in most of the patients, i.e. this drug is very, very well tolerated. And only 5% of the patients were just discontinued the drug, and the dose reduction was noted in or observed in only 2.5% of patients. So very few required lowering of the drug dose or discontinuation due to side effects. Now there is another new kid on the block, which is not approved for patients with WM, but has been examined in patients with WM, has been evaluated in these patients, and is approved for other B-cell malignancies such as CLL, etc. So venetoclax can be given as a monotherapy, and this was determined almost 10 years ago, where in a very small study, they found that all patients with WM responded. And then a subsequent study was done with about 30 patients, 32 to be precise, and this study used venetoclax for only 2 years. And what you can see is a very steep curve, a steep drop in the curve on the right-hand side in the figure, and that is at the time of within 6 months of discontinuing venetoclax, a lot of patients progressed, telling us that if we are using venetoclax, we should be giving it on a continuous basis without discontinuing unless the patients have significant side effects. Thankfully, this drug is also very well tolerated, and fortunately, patients with CXCR4 mutation also do fairly well on this. So this is the way we at Mayo Clinic treat patients with relapsed refractory WM. At the first symptomatic relapse, if they've been previously exposed to a covalent BTK inhibitor, we give them chemoimmunotherapy. If they haven't been exposed to covalent BTK inhibitor but have previously seen bendamustine or another chemoimmunotherapy, then we give them zanubrutinib. Rarely we have to repeat the original fixed duration because now we have other options. Now, in the second line, after they have seen chemoimmunotherapy as well as covalent BTK inhibitors, we have a number of options, including venetoclax, pirtobrutinib, proteasome inhibitor-based regimens such as BDR that I just talked about initially, and even autologous stem cell transplant. Although I would say in the past 10 years, I haven't taken any patient to autologous stem cell transplant because of such good treatments that we have available today. And one such good combination is currently being evaluated, and this study is being performed under the umbrella of WMNet, which is a consortium of WM centers across the US. And this study is specifically combining pirtobrutinib and venetoclax together. It's a 40-patient study, and the initial 16-patient response was presented at the American Society of Hematology meeting last year. Deep remissions are noted, and the vast majority of patients remain progression-free, although I should say the follow-up is short at just 6 months. Fortunately, we have a lot of targets available for us. We have not only the BTK, but also BCL2. We just talked about that. We have CD20 with novel therapies. We have CD19. We have found that another potential target could be targeted, and that's BCMA. That's predominantly present in patients with active Waldenstrom macroglobulinemia as well as in relapsed disease. And there are, fortunately, agents against it, therapies that have been used in other cancers. And sonrotoclax is the next generation BCL2 inhibitor, which has been used in clinical trials and is currently being examined as we speak. Fortunately, the drug is very well tolerated, and we now have a dose of 320 milligrams that has been shown to be very effective and fairly well tolerated. And this is a more potent BTK inhibitor, BCL2 inhibitor in comparison to venetoclax, and certain resistant mutations that could potentially develop on venetoclax can be tackled with sonrotoclax, and early data is very promising. Another drug is loncastuximab, and this study was performed by Dr. Shana Sarosiak at the Dana-Farber in collaboration with Mayo Clinic and Fred Hutch. And what was found was that even in this small study of 14 patients, CD19 was targeted. It's an antibody drug conjugate which allows delivery of a specific DNA-damaging payload called pyrrolobenzodiazepine, and that essentially destroys the WM cells. What was notable in this study, even though it was a small study, was that 57% of patients had this dreaded TP53 alteration. And those patients, interestingly, did even better than the ones who had TP53 wild type. So there is a target, and there is also a drug that could potentially work in these patients. And even though the drug was given for a limited duration of time, just 6 cycles, each cycle of 28 days, this drug could keep the patient's disease at bay for a fairly long time, although I should say the follow-up is still short and more data need to be generated. There are some side effects which are unique, such as fluid collections in certain cavities around the lungs, also skin toxicity, and liver enzyme, specifically GGT elevation, although all the patients who had that were essentially asymptomatic. Another very interesting concept that is currently being examined in WM patients is the use of CAR-T. There is a CAR-T, CD19-based CAR-T trial that is currently open at Mayo Clinic. There was another trial of a very promising agent called MB106, a CD20 targeting CAR-T therapy. Now, what CAR-T therapy does is it allows us to collect the patient's own white blood cells, specifically lymphocytes, and then change them, alter their structure in such a way outside the body that they become really powerful soldiers, and then we reinfuse them, and after reinfusion, they attack the cancer cells, specifically the Waldenstrom cells. And when this battle is going on between the armored soldier as well as the cancer cells, the enemies, there's a lot of different types of chemicals that are released, and that can be potentially toxic to the human body. It's called cytokine release syndrome. That is one of the side effects of this type of therapy. But fortunately, we have antidote or drugs to counter that. And in this specific third generation CAR T, which had what we call co-stimulatory domains that allows the CAR Ts cells to attack powerfully the enemy cells, we found that the CRS rates were rather low, and the patients did fairly well despite having a very high degree of exposure to previous agents. And what you can see here is that around 90% of the patients responded, about 50% had deep remission, and the grade or severity of CRS was rather low, only grade 1 and grade 2. Unfortunately, the study had to be halted because the sponsor withdrew support, but the drug would likely get resurrected because of interest from other pharmaceuticals. It was a drug developed by the Fred Hutch scientists. Another very interesting molecule is the MALT inhibitor, the activity of which was actually shown in a small study. It was a basket study involving different B-cell malignancies. And specifically, if you look at the Waldenstrom patients, which is right in the middle, there were only 5 patients. All of them achieved a response, and you can see a PET scan on your right-hand side, which actually shows that it's quite active disease or lighting up initially. And once this agent was started, it's an oral agent, the patient's response was dramatic, and there was a shrinkage of the tumor size. It's early stage, but very good data, and the results appear to be promising, as do the results from this Cadence trial. In fact, this is a BTK targeting, but a BTK destroying drug called BTK degrader. Like zanubrutinib, like pirtobrutinib, this is also given orally. And what it does is it brings another enzyme, it attaches or latches on to BTK and brings another enzyme close to the BTK so that that enzyme can tag that BTK, and then BTK in turn gets destroyed by the machinery within the cell called proteasome machinery. So a beautiful mechanism of action, and it's not just the enzymatic function of BTK that is taken care of or targeted with this approach, but also the scaffold function where the entire structure is damaged and all the downstream signaling is impacted as such. And these patients who were heavily pretreated, almost all of them were, 100% of patients were exposed to BTK. These patients did fairly well at a small dose of 100 milligrams, and there was deepening of response noted over time with a major response rate of 81%, and 95% of the patients had their disease under control. The follow-up time in this study was short, but there is more and more data that's being accumulated, and most patients are continuing to tolerate this treatment fairly well without development of any heart-related abnormalities or hypertension. And as such, this is a very promising agent. There is another very similar drug called NX5948 or bexobrutideg, which is very similar to the catadeg-brutinib that I talked about in the previous slide. This is developed by a different company, again, highly effective in tagging that protein and ultimately destroying BTK. There are some side effects noted, including cytopenias as well as risk of infection, but once again, no cases of atrial fibrillation. I'm going to end on this. There's a promising, hopefully, I should say, study that we are going to start at Mayo Clinic, and it will also be started at Dana-Farber, using a drug that has been shown to be exceedingly promising in multiple myeloma. This is a BCMA bispecific. It is bringing the soldier cells close to the enemy cells, in this case, multiple myeloma, where it's been tested, and our hope is that it would have similar activity in Waldenstrom macroglobulinemia as well, where it will latch on to BCMA at one end and CD3 on the WBC or white blood cells or soldier cells, and as a result will lead to killing of Waldenstrom cells. So this study is about to start in patients who have been previously exposed to BTK inhibitor. One more agent that has been found to be somewhat promising is this iopofosine. It's a phospholipid drug conjugate that binds to lipid rafts and is internalized. It then releases a radioisotope called I-131. So it's delivering radiotherapy to the cells, specifically WM cells that have a lot of lipid raft, with just 4 doses. Initial cycle is given, it's a 28-day cycle. 2 doses are given 2 weeks apart, and then there's a gap of 6 weeks, and then 2 more doses are given. And patients who receive all 4 doses have been found to have really good response with a major response rate of 58%. And these are also heavily pretreated patient population, and we will see some updated data that will be presented at the American Society of Clinical Oncology meeting on June 1st in Chicago. So hopefully we will continue to see development of such agents that could tackle the patient's disease over their lifespan and could give them good quality of life for a long duration. And with that, I end my talk, and it's open for questions. Oh, that's fine. Thank you.
We've still got a little time for questions, and I have one mic here, right behind you, Katie. And I'm sorry.
Not making me look.
You're welcome. Hey, thank you very much, Doctor. One just simple question. You keep using the word deep or deepening response. Could you be more specific about what you mean by a deep response?
Sure. Thank you for that question. It's a great question. So response to different patients, that word has different connotation, but in the medical field, response means we are killing Waldenstrom cells at a high level. What that means is that because we are measuring it indirectly by looking at the IgM levels, if there is a 50% decrease in the IgM level from the baseline, that means there is partial remission or partial response. If there is a 90% reduction from the baseline, in other words, if somebody had 3 grams of protein initially and now has only 290 milligrams, that means there's a 90% reduction. That patient is in very good partial remission. For complete remission to occur, we have to have absence of Waldenstrom cells in the bone marrow, plus no detection of M protein or monoclonal protein in the blood. And that is not always feasible. In fact, it's only seen in a minority of patients with the current treatments that we have. But we are hopeful as we start to combine certain of therapies together, but give them for a shorter duration instead of indefinitely, we'd be able to achieve deeper remission. So conversion from PR or partial remission to very good partial remission, that's deepening of response. The deepest response would be MRD negative state. We are starting to see that in some patients with certain drugs, especially if they're used in the frontline setting. But this is a place where we need to do more research in order to find out what the most effective combinations are, where we, even after looking with very sensitive tools in the bone marrow, we are unable to detect any evidence of Waldenstrom.
Hi, and I'm going to butcher the name. Alcabrutinib?
I'm sorry?
So I'm going to butcher the name of the drug.
Acalabrutinib?
Thank you.
Yeah,
That's it.
sorry.
Wasn't there a recent study, though, that it showed that it was pretty good drug for WM patients? And would that be a next step for some people that are relapsed?
So acalabrutinib, there's been some update by Dr. Roger Owens just in the past month, actually, on the study that was conducted several years ago, and they've reported their data periodically. So it's not a new drug. Acalabrutinib is a covalent BTK inhibitor, so you can think of it as a cousin of ibrutinib or a cousin of zanubrutinib. If somebody is relapsing on zanubrutinib, I would not be using acalabrutinib because the study actually did not allow patients to receive the drug if they had previously received a BTK inhibitor. On the other hand, if somebody is on zanubrutinib and is relapsing, that's when a degrader would potentially be helpful, or a non-covalent BTK inhibitor, or chemoimmunotherapy if they haven't seen, or venetoclax, or some bispecifics, or CAR T. The list keeps going on and on with every passing year.
Okay, two more questions only, so.
Sure.
If someone was on Imbruvica 4 years ago and then had subsequent treatments and has relapsing, would it be too soon to go back to or to try zanubrutinib?
So again, this question it's a great question, somewhat related to the previous question. Uh, the specific question would be, why was Imbruvica or ibrutinib stopped? Was it stopped because the disease was not responding? In which case, zanubrutinib wouldn't work. But pirtobrutinib, which is not yet approved for patients with Waldenstrom, but is available in the market for patients with CLL and mantle cell lymphoma, that drug is out here available. It's in the market, but we are at that time at the mercy of the insurance company, whether they would pay or they would say, no, we don't. Fortunately, most of the insurance companies, to my experience, when we provide them with the data that's available, are able to allow us to use. And that's how the example that I gave you of the patient who progressed on zanubrutinib, we gave pirtobrutinib and is now responding to it. So some of these drugs, unfortunately, even though they are approved for certain indications in Europe, they are not available because the government is essentially paying, and the government is actually also providing the drug. And so there are specific indications that and rules that they have to follow.
There's one final question.
I have a question about BTK in general. Is it normally a positive protein? And if so, if when it's degraded, is that what causes some of the side effects from the medications?
That is a great question. It is required because Bruton, the scientist who actually described this protein, has shown that this enzyme is actually very important for white blood cells specifically. It's also present in other cells, and this enzyme allows cells to function normally. And in the absence of this enzyme, there can be hypogammaglobulinemia or reduced antibodies, in turn leading to increased risk of infections, etc. So that is one of the side effects, for instance. Some of these molecules, the degrader is more specific, but some of these molecules, like ibrutinib, etc., are not as selective as, for instance, the next generation Acala and Xanu. And ibrutinib can act on several enzymes which have other tyrosine kinases which have similar structure to BTK, and as such can lead to higher toxicity. So the selectivity of the agent matters a lot. And the more selective the agent, the lesser the side effects.